Hello. Good morning. So nice to see so many people out here, such a wonderful turnout. A lot of familiar faces, a lot of new faces. For those of you who don't know me, my name is Dr. Suketu Khandhar. I'm a movement disorder neurologist at Kaiser Permanente in Sacramento. I am a PANC board member and happily so for the past 8 or 9 years now. I want to first thank Larry for inviting me to speak here today, although you're really not going to be hearing me speak so much as you are the panel. And that's something that's unique to this seminar as opposed to previous year seminars. So in the previous years, the format has always been a lecture format. You hear a few speakers, they'll maybe talk for about 30 to 40 minutes. There's a little bit of Q&A afterwards. But over time, there's an abundance of information and sometimes can be quite overwhelming. All too often, the physician community tends to fixate and focus on patient motor symptoms, the tremor, the stiffness, the slowness, but hardly ever do we address wellness. And that has been the basis of today's and the theme for today's seminar. So what is wellness? Wellness really is going to be looking at not just your motor symptoms, how well you live with Parkinson's, but also your non-motor symptoms. So we've invited a wonderful expert panel here today, and that panel consists of nutritionists, a functional medicine physician, I'll allow them to explain what they do, neurotherapists, Dr. Thakur from Sutter Health, and I will be moderating that panel. The architecture of this panel is going to be in the first hour. We will have each of those speakers give about a 5 or 10 minute presentation as to who they are, what they do, and a few key pearls for you to all take home with you, hopefully answering a few questions that you may already have. We won't have questions just yet, and hopefully after the end of the first hour, if there are some time, I have some pre-populated questions that I'll be asking the panel. What I want from the panel is a healthy discussion between them in order to generate some dialogue that might help you all, not just patients, but also caregivers alike. And then there'll be about a 15-minute break, and each of you have a note card that should be in front of you. Please, in that first hour, take the time to write down questions, burning questions that you may want to hear the answers to, and then bring it to my attention, or PANC volunteers will bring it to my attention. I will filter these questions. I would imagine many of the questions will be repetitive. And I'll go through those questions, and in the following hour, we will ask the questions of the panel. These questions shouldn't necessarily be directed to any one speaker. My hope is that these questions will hopefully be answered by many of the speakers. That being said and done, I would first like to thank Larry and the Parkinson Association for putting such a wonderful event together and having such a great idea to put a panel together this year. I also would like to thank our host here, the Crown Plaza Hotel, for giving us such a wonderful venue. Last year, we had to scramble last minute and do it at the McClellan Air Force Base. For those of you who were there, knew that there were some issues with the speaker system, so hopefully we are not echoing here today. Without further ado, I'm actually going to go ahead and invite our panel to come up here, please. So Darlene, you should be there. Christine, Aaron, Soham, you're over here. I think you're in the middle. So our first speaker is Darlene Isbell. Darlene is a registered nutritionist, then dietitian. She actually trained at the University of Hawaii. She had her MPH, or Masters of Public Health there, and has also worked for the Navy, where she actually trained to be a registered dietitian. She has been in this practice at Woodland, at the Woodland Healthcare. And we're wonderful to have her here today because nutrition has been always a question that's asked in my clinic and I hardly ever have the answers for other than please eat a healthy diet. So I'd like to invite Darlene to come up here and give a few words about nutrition and Parkinson's disease.
Good morning. My name is Darlene Isbell. I'm a registered dietitian and certified diabetes educator. Welcome. I'm going to be discussing healthy eating for a lifetime. Now you might want to say, why am I talking about healthy eating? In order for if you're the caretaker, and you would probably want your person with Parkinson's to stay healthy. In order for that to happen, the caretaker needs to stay healthy. So we're going to you also have, some of you have handouts, which is provided on your table or on your chair, but the people in the back may not have handouts. I chose not to use a PowerPoint because when I've gone to presentations and I sit in the back, I can't see what's going on. Okay, what we use for healthy eating is from the USDA government, and it's on choosemyplate.gov. So what's on your plate? Servings, before I begin, serving sizes are very, very small, okay? And we're emphasizing vegetables, fruits, grains, protein foods, and dairy products. We live in California. This is the salad bowl of the United States. Because I recommend you eat at least 3 meals a day. Snacks are great, but at least twice a day, half of your plate are non-starchy vegetables with a lot of color. And we're talking about a 9-inch plate, half of your plate. And what are the non-starchy vegetables? They're all vegetables except corn, potatoes, and peas. And you want to choose your vegetables with a lot of color. What am I talking about? I'm talking about broccoli, I'm talking about bell peppers, things with color, kale, spinach. These are colorful vegetables which are green, orange, yellow, purple. A serving size is half a cup. And we're talking about a measuring cup. If it's cooked, it's a cup if it's raw. And if it's a leafy green, something like raw spinach or raw arugula, it's 2 cups of leafy greens. I also recommend that you have at least 2 to 3 servings of fruit, and we're talking about whole fruit, not juices. I recommend my patients drink 2 things. Water. If you choose to drink milk, that's fine. I find that lots of my patients don't drink milk. If you choose to drink coffee and tea, that's fine. I recommend you eat the fruit and not drink the juice because of the fiber in the fruit. And and as I said, we're in California, we're in the salad bowl of the United States. Choose fruit with a lot of color. What am I talking about? I'm talking about any of the berries. I know we're between seasons with oranges, pink grapefruit. We've gotten out of the summer fruit, apricots, cantaloupe, watermelon. A serving size for a fruit is the size of a tennis ball, very small. Banana serving is this big. So if you got this big, that's 2 servings. So just cut it in half and share it with your partner. I recommend your grains to be whole grains. I know the government says make half of your grains to be whole grains. I say, why don't you just make all of them to be whole grain? Okay, what's whole grain? Whole wheat bread. If you eat rye bread, it's whole rye bread. And if you read the ingredient label, it must read whole rye meal. It would not say, because rye is not a wheat. Like if you want to know it's a whole wheat, you want to say whole wheat flour. So rye would be a whole rye meal. Things like whole grain pastas, whole wheat pastas, whole grain crackers, they're stone ground corn tortillas, brown rice, bulgur. Oatmeal is a whole grain cereal. If you bake, it's whole wheat, using whole wheat flour or other whole grains in cooking and baking. You also, as I mentioned before, check the ingredient label that you see the word whole. Lots of times, you see it says grains, and you read the ingredient label, they'll say enriched or unenriched or refined. That is it's not a whole grain unless you see the word grain. So make all your grains to be whole grains. 1 serving size is 1 slice of bread. Half a cup of cooked rice or half a cup of cooked oatmeal is a portion. For the meat servings, you want to choose it lean and healthy. Choose more fish or poultry, the white part. Trim all the fat off. And things that are lean, if they're beef or pork, would have the word round or loined in it. You want to bake, roast, grill instead of frying. And beans are great foods. Beans, lentils, legumes, nuts, and eggs also count too as protein. A serving size is in your handout. All you need in a day is 6 to 7 ounces. 3 ounces is a palm of a woman's hand or deck of cards. So you need 2 deck of cards. Most people, if they looked at the plate, they want half of their plate to be meat, right? It's not half of your plate to be meat. Okay, so you do have a handout that tells you what a serving size for the protein, because protein is very important. Lots of times when people get older, they don't eat enough protein, so that's a real big concern for our elderly population. Your dairy products, you want to choose 1% or non-fat dairy products, or fat-free or 1% yogurt. A serving size is a full cup. For your added fats, use less butter, use less margarine, mayonnaise. You want to choose heart-healthy oils such as extra virgin olive oil or canola oil. If you use margarine, I would recommend you use a tub margarine, but it's all about how much you use. I'm a registered dietitian, and I use real butter. And the reason I do that is the only time we use the butter is when we eat English muffins. And I may only buy English muffins every 6 weeks, so we don't really use that much butter because it's how often and how much you eat of something. You can eat a perfectly healthy diet, but if your portions are too large, you can probably weigh more than we recommend. And the reason I'm saying that is our number 1 health problem in the United States is obesity and overweight. We are number 1 in the world, leading the entire world in obesity and overweight. That is not a good thing to be number 1 in. Okay, a teaspoon, not a tablespoon, is a serving of oils and fats. If you go to a salad bar and you use that ladle, that's 1/4 a cup. That is 400 calories, 1/4 a cup. You also have in your handout 10 tips for adding more vegetables. I've been a dietitian for years. I find that most of my patients do not eat enough vegetables. Half of your plate to be vegetables. The question might be, I'm taking Parkinson's medication. The only recommendation I would say is, if you're taking a Parkinson's recommendation, you want to do a trial period for a couple of days to see if the protein affects your medication. If it does, you take your Parkinson's medication 1 hour prior to eating a meal with protein or 2 hours afterwards. I do have some resources. It would be choosemyplate.gov. The VA has some excellent resources. It would be moveva.gov. Thank you very much. That's yours.
Thank you, Darlene. I think if I were to have lived under Darlene's roof, she would have probably reprimanded me 5 times this week with that supersized meal that I had at McDonald's the other day. So I also want to congratulate George over there. You live with her. I'd like to invite our 2 neurotherapists from Kaiser to come up here and give us a description of what neuro-PT is. Majority of the physical therapists actually graduating from training tend to be orthopedic therapists. They're wonderful for that hip replacement and that knee replacement, but don't necessarily understand what involves neurotherapy. So very few therapists out there actually have subspecialty training in treating Parkinson patients, but we have two of them here today, so I'll let them speak to that. Erin Vestal and Christine Shade, both are two of our neurotherapists from Kaiser Roseville.
Hi, I'm Christine Shade. I'm a physical therapist at Kaiser Roseville. First, since I'm from physical therapy, let's have everyone try and sit up nice and tall so we all have good posture during our little lecture here. So shoulder blades should be pinched together. Very nice. So my patients out there hear this all the time. Oh, is that up? There we go. So Erin and our objectives today, we will be talking about Parkinson's disease and the typical treatment options, neuroplasticity, can we change our brains, and exercise as medicine. You are in control of your Parkinson's disease. So the new concept of thinking is definitely exercise as medicine. It's cutting edge research. Right now, there are tons of articles coming out almost daily on Parkinson's and exercise. Exercise is a physiological tool that promotes brain health, repair, adaptation, and behavioral recovery from the inside. Neuroplasticity, I love to talk about this with all my patients. This is what gives everyone hope. Neuroplasticity is that the brain can change. So it doesn't matter. Research shows if you're 0 all the way to 100, we can change our brains. And it doesn't matter how injured the brain is, we can still change it. So here's just another thing about neuroplasticity. It provides us with a brain that can adapt not only to changes inflicted by damage, but allows adaptation to any and all experiences and changes we may encounter. Dr. Jay Alberts had kind of happened to just come upon this forced exercise movement. He was doing a tandem bike ride across Iowa with a patient. So they were doing a week-long bike ride, and day 2, the patient actually said, I'm feeling pretty good. They had decreased motor symptoms, and their handwriting actually really improved. So from that, he noticed, he was keeping the bike about 85 RPMs. So he started doing a lot of research on forced exercise. So the patient actually has to be active with the exercise, but it's forcing them beyond what they could do on their own. So up on the screen are some different MRIs of a patient's brain. So on the far left, there's after 9 Parkinson's patients with mild to moderate Parkinson's rode a stationary bike, and they maintained between 80 to 90 RPMs, and this MRI was taken 3 hours after and off medication. The middle MRI is a patient off, the same patient about a week later off their meds, and then on the far right, the patient on medication another week later. But the encouraging thing about this is that they actually found, and you can see on the slides, that there's increased blood flow and increased motor activation in the areas of the brain that are similar post-exercise and on medication. So what that shows us is by just exercising and working very hard, you can get the same benefits as taking your medication, which is very powerful and should be very empowering to all of you, just knowing you can go out and work hard every day and feel a little bit better. There was another recent research study done. It just came out this July in the study of neurology. They did a 6-month study, so they did, or it was over 3 years, but they took people and they did 6 months. They worked out 3 times per week for 45 minutes of walking, and all the patients had mild to moderate Parkinson's disease. They split people into groups where they worked out by themselves and people in groups. The area that they studied it in was pretty rural, so most of the people were just working out on their own. But there were improvements in all the groups. So they showed increased motor function, increased aerobic fitness, increased walk time, increased cognition, and increased quality of life. So I don't know about you guys, but if we all just get out, right, walk 3 times a week, that's not a bad trade-off, right? The next study was a 24-week treadmill training study. And this one is interesting because they actually compared treadmill training with speed training and using different inclines. And then they compared them to a group that just did speed training. And then the control group, they just did light exercise. So they did Tai Chi and gentle like chair exercises. The outcomes for that one, they actually showed the group that had the biggest improvement on quality of life using different scales was actually the mixed treadmill training. So doing the incline and the speed, they had the biggest improvements of quality of life. And both treadmill groups did improved endurance and improved walking speed. So on this slide here, it's like a crazy circle. So we have the people working out, the goal-based aerobic exercise. So that's really hard intensity. By doing that exercise, they've actually proven that it increases synaptic strength. So they have increased neurotransmitters, increased receptor density, increased dendritic spine formation, and improved drug efficacy. So from that, you have increased strength and circuitry in the brain. And then also you have improved brain health, so increased trophic factors, increased blood flow, increased immune system, increased neurogenesis, and increased metabolism. And that all helps improve behavior. So decrease fatigue, prevent depression, improve cognition, improve mood and motivation, and improve sleep. So how does exercise change the brain? The bottom line is exercise optimizes the brain health and efficiency. So it protects vulnerable neurons from stress and toxins. It enhances the recovery of damaged circuits, and it helps the brain adapt to do more with less. So now I'm going to hand it over to my colleague, Erin.
Okay, so if you all thought you were done sitting up tall, you're not. So again, we need to sit up tall, right? We're all the PTs are watching. So on this slide, this is probably one of my favorite slides. We all know that you guys are here. You didn't choose to have Parkinson's. Parkinson's unfortunately chose you. But you guys also have a lot of choices about how you manage your Parkinson's and how you move forward with your Parkinson's. So what Christine spoke about earlier kind of lays the foundation really for the idea that we want you guys all to get out there and exercise. This slide just really shows a lot of different activities because it doesn't have to be the treadmill necessarily. It doesn't have to be specific activity. Dance classes, yoga classes, all kinds of different activities that are in the community, or you could take through your healthcare providers or go with your caregivers, loved ones, etc. here. So just one more study, well, 2 technically, that I wanted to tell you guys about that involves the number of steps you take and talked about the intensity of the exercise. A lot of patients ask us, well, is it okay if I'm just going to get the mail or I'm going to go to the mall or to go to the shopping center? And no, we're going to say that's great. We're glad you're out and active, but we really need to think about how much you're doing. So this particular study showed the difference between taking only 6,000 steps on a little mouse, so a little mouse wearing a pedometer, versus a little mouse wearing or taking 18,000 steps. And so the animals that took 18,000 steps experienced all those benefits that Christine spoke of for the brain. The brain was protected, it had better efficiency and so forth. So the reality there is the more you do, the better. And of course, the other piece here is, can I just exercise for like a month and then I'm good, right? No, this has to be a lifelong journey. As you can see in the study here, again, this was animals, but the animals that exercised as a lifestyle change had the neuroprotection occur. So the bottom line, and you'll hear this from Christine, me, probably also Suketu and Dr. Thakur over here, everyone, more is better. We want you to be active, okay? So this one kind of goes over a lot of what we've already spoken about. We are encouraging you to get out and be active, increasing survival rate, cognition, quality of life. But the biggest piece I want you guys to pay attention to is the 2 bullet points on this slide. This one hit me pretty hard as a PT when I was continuing my training in Parkinson's disease, and I really realized through a few of these studies that if you are inactive, it's actually pro-degenerative. So by not being active, you're actually making your situation worse. And none of us want that, right? We're all here because we care about Parkinson's and we want to be better and do better. So the idea here really is to make sure that you are being active in some way and you're not increasing your chances of degeneration, okay? And here what I wanted to make sure everyone saw was that these studies all showed improvements with exercise no matter the stage of Parkinson's. People think, oh, if I'm in my end stages, then gosh, I can't start now. But that's not true. You can see here that even someone with advanced Parkinson's disease did still experience improvements, cardiac improvements, respiratory improvements, and the brain damage markers are decreased, and of course the behavioral recovery. So that goes into what we've spoken about too. Parkinson's is more than just a motor issue, right? There's quality of life issues, there's sleep issues, digestion issues, and those folks, no matter if they were early in the disease stage or later, all experience improvements. So really, Dr. Khandhar hit about this briefly. As physical therapists, I think a lot of PTs are afraid of the neuropopulation because they think, oh my gosh, what can we possibly do? These people have something so profound. But in reality, these studies have provided Christine and I with a lot of hope and our clinical experience treating patients that continuous exercise, we've seen our patients, we've seen them improve, we watched it happen. And slowing down the motor deterioration and improving quality of life is really why we do what we do. So the question is, where do I start? That's what a lot of patients ask us, and we tell them, do anything you want, right? But we talk to you about intensity. We talk to you about not walking to the front door as your exercise. But working with a physical therapist or a community provider can help you find those right avenues for you. But we want you to enjoy it and have fun. And so we put also this slide in because this is the World Health Organization recommendations. I'll let you guys read over that, and Christine hit on it. But we want you guys to do a little something active every day. If you can spare 10 minutes at a time, go for a walk, ride a stationary bicycle, and commit yourself to the exercise, we can pretty much guarantee, I think both of us have seen, you will see changes in all of your symptoms, not just motor symptoms. So we want you guys to start early, avoid inactivity. I can't say that enough, and I'm sure Christine would say the same. Intensity matters. Push yourself. It's okay to sweat. It doesn't, it's good for us all to sweat a little bit and work hard. And certainly, really involve your spouse, involve your caregivers, involve your connections that you make here in this room, and exercise with other people with Parkinson's if you can. And realize, really, if that saying is kind of cliche, if you don't use it, you lose it. But it is really, really true, especially in the Parkinson's community. And of course, the bottom line here is you're benefiting, right? We're asking you or giving you the tools. It's really about empowering yourself to continue with this and realize you will see improvements. So in closing today, guys, really the question for us is not how to survive, but thrive with passion, compassion, humor, and style. And of course, we're going to tell you that the best way to do that is a little bit of exercise. Okay? So thank you, guys.
A lot of my patients have heard this in my clinic, so I apologize for being redundant. But I have learned over the years that the trifecta of a successful treatment is three things. Number one, education. Education for their patient, education for their loved ones. Number two, therapy. Things such as physical therapy, occupational therapy, or speech therapy. And number three is the medication. I put that last because I think it's the least important of the three. Okay, when I first started doing Parkinson's management, it was the most important thing to me. And of course, I was a young kid out of residency, so I thought I knew everything. It isn't everything, okay? And now that I tell that to patients, I feel more empowered to be able to explain that to them. And I think patients and their loved ones also feel more empowered in hearing it. Just recently, in the last couple of weeks, I had a patient who said, "Oh, I'm active. I do a lot." And the wife sitting in the background going, "No, you don't. This is an activity." I'd like to invite our next speaker, Dr. Soham Jhaveri. Is actually an old friend of mine. We actually went to college together. He did his training at USC and now works for the Palo Alto Medical Foundation as an internist. However, his passion lies in functional medicine. I'll allow him to explain to you what that is.
Very excited to be here today and share with you my passion for medicine in general, and also in talking with Dr. Khandhar for so many years about Parkinson's disease, sharing some of the things that I've learned throughout my career. So I find that, like any chronic illness, many times what gets really forgotten between the research that you see up on the screen, many things that gets forgotten is the patient, And patients always have this overwhelming sense of loss of control, especially when it comes to chronic diseases. And I think, especially with an illness like Parkinson's, it's even more difficult because the mechanisms of what's happening is very complicated to understand for patients. Sometimes even their own primary care doctor doesn't understand very well, what exactly you're going through. And that's very true for me. I don't understand everything about Parkinson's. And, I know a lot about diabetes and high blood pressure, but if you ask me, what are all the manifestations of Parkinson's, I couldn't rattle them off to you. So it must be very difficult from, in your seats for those of you who have Parkinson's to really, understand what your disease process really is and what's happening. And I think that rather than just focusing on your specific disease process, I like to approach it in a different way. I like to say, what can we do to help you take power back? To have ownership over what's happening with you and really approach your care in a fundamentally different way. And that's what functional medicine is, I think. And that's kind of what I like to practice in my clinic, which is to give individualized care for the person who's sitting in front of me based on their set of life experiences and problems. And I think that self-care should be the heart of healthcare. That's what I've been taught. And that's not something that I came up with. A lot of smart people ahead of me who have taught me that. So in really approaching patients, the number one thing that I like to do is really get to know them and really get to know their life story about how they actually got here to my clinic to the point where they may have Parkinson's, for example. What things in their life, stresses, illnesses, could have potentially contributed to them, and really create a dialogue with patients about what's happening in their life, rather than just symptom management. Okay, you have this symptom, therefore we'll give you this remedy, medication to help treat it. And I think that by doing so, I empower the patient to take ownership. And there are lots of tools that I actually give, and I'm hoping today to give you all some tools that you can use immediately when you leave here today to be able to use in your daily lives to help. And I'm going to try to go through some of them. And I think that by using some of these tools, you can perhaps gain a sense of more power over your illness. And interestingly, I'm actually going to go through some of the things that I've already spoken about before. Specifically, I want to go over dietary guidelines that I like to give my Parkinson's patients, help with sleep, activity, as the physical therapists have noted. Sometimes I use supplements in people to try to help them. And the last thing I would go over is like mind-body techniques that I actually will teach my patients in the clinic. And actually, this is a great way to kind of learn this. And at the end of my talk, for about 2 minutes, I'd like to go through a mind-body technique that I could teach you all. And hopefully you'll be able to do it immediately and go home and be able to practice it. So the number one thing I want to go over is kind of the dietary guidelines. And I'm not going to go into as much detail as Darlene did, but I will disagree with her on a couple of things. Let me say what I do agree with her on, that everyone needs to eat more vegetables. But a couple of things that I do want to disagree with her on about is specifically the guidelines that the U.S. government puts out are for everyone. Well, unfortunately, many of you have Parkinson's disease, and that requires a very individualized approach to your diet, rather than just saying carte blanche, everyone should be doing this. That's a great, okay guideline for a whole population, but specifically for Parkinson's patients, I would like to have a couple of different things that I usually suggest to my patients. So the number one thing is, the way I think about Parkinson's disease, I think about Parkinson's disease like any disease, whether it's diabetes or high blood pressure, is that I feel like there is some sort of inflammatory component to Parkinson's disease, and therefore you have to eat some anti-inflammatory food. Now, the number one thing that I agree with what Darlene said was eating a lot of color in your vegetables. All of those colorful vegetables are all anti-inflammatory. They reduce inflammation in your body, and that's going to help you at a very foundational level of your life. The number two thing in terms of that is this suggestion of, you should have some level of dairy product in your diet. Well, in general, I find that if you are going to have dairy products, I disagree with Darlene. I think you should have whole milk, whole fat milk, rather than 2% milk. And that's just because I believe fat doesn't make you fat. It depends on where that fat comes from, okay? And so, and I find that I generally like to say avoid dairy products because they tend to be more constipating, okay? And many of you have that problem where constipation is a big issue. So therefore I say, as much as possible, try to avoid dairy if possible. Switch to coconut milk, almond milk. Those are probably better options for you. The other thing that I want to say is you have to avoid red meat because red meat is very pro-inflammatory. It will increase inflammation in your body, so you should try and avoid that. That's what I tell my patients. And the other thing that I'd like to avoid is actually too many grains in your diet. So, interesting fact, 2 slices of whole wheat bread make your blood sugar go up faster than 2 spoons of sugar, like white sugar, okay? So this whole thing of like, yeah, you should have these certain grains, I kind of disagree, and I kind of tend to tell my patients specifically to avoid these certain things. So basically the bottom line with respect to diet is try to eat more anti-inflammatory foods, which are cooked vegetables, not raw vegetables, because raw vegetables also tend to make you more constipated and are difficult to digest. And if you already have a very slow digestive system, you don't want to slow it down further by making it difficult for your body to digest that food. So I actually think that you may eat salads, but try not to eat too many salads because that's going to make your digestive system potentially slower. Number 2 thing I want to talk about is sleep. Sleep is a big issue in Parkinson's disease patients, and I think that setting up a routine in your life is very important to help get to sleep at the same time every day and wake up at the same time every day. And in particular in Parkinson's patients, from talking to Dr. Khandhar, I know that falling asleep tends to be a little bit easier, but staying asleep tends to be more difficult. So, if you have a good relationship with your primary care doctor, there are various ways that we can try to help give you the tools to help you sleep better, but also this is going to be a big challenge. And things that I do for my patients is sometimes I like to give some supplements to help them with sleep. There are actually teas that you can drink to help you, help you stay asleep, that sort of thing. And I'm hoping to create more questions so that we can answer them when the panel discussion comes up. Number 3, I'd just like to echo what the physical therapists said nicely, which is exercise. I really think Tai Chi is a great exercise for Parkinson's disease patients. There are lots of studies that show that Parkinson's disease patients are benefited by doing Tai Chi, and I think that movement, especially walking at least 30 minutes a day, would be very helpful. The number 4 thing, what I talked about, is the use of supplements to try to help you, and I specifically speak with my patients regarding what supplements they should be on depending on their need. So it's individualized to every person, but in general, I like to recommend fish oil for my patients because it's anti-inflammatory, and we can talk about specifics if there are specific questions that pop up, but I generally like to tailor them to the individualized patient. And the last thing is mind-body techniques. So I think that mind-body techniques are very important. There are many mind-body techniques that we can use to help Parkinson's disease patients and all patients really. And if it's okay with you, I'll like to spend about 2 minutes of time taking you all through a kind of a mind-body medicine technique that I use. And how am I doing on time? And I use these techniques, and I think we can all do them together this morning. So what I'd like you to do is kind of sit back in your chairs, everyone, if possible, and keep your palms kind of on your legs, kind of palms up, okay? And I'm going to explain to you briefly what we're going to go do, and then we're going to all do it together. Okay, so what I'm going to explain is this is called soft belly mind-body medicine technique. It's called soft belly, and it was put together by James Gordon, who's a physician out of Washington, D.C., and essentially what we're going to do is we're going to take a couple of deep breaths, 2 deep breaths that are kind of cleansing to kind of reset your body. And then during this entire thing, we're going to make sure that we breathe normally. So we're not breathing deeply throughout the meditation. We're doing normal breathing. And what I want you to do is at the end of inhalation, so when you inhale, there will be some end of that inhalation. I want you to say the word soft. And then immediately afterwards, I want you to say the word belly. Okay, and by doing this, what you're doing is you're actually softening the belly, the diaphragm. Okay, and when you do this, you'll. I think this is experiential, so let's go ahead and do this. If you could please close your eyes, everyone, and let's just take 2 deep breaths. Normal breathing, soft belly, soft belly, soft belly. Everyone must say it out loud, please. Soft belly, soft belly, soft belly, soft belly, soft belly. Soft belly. Let your body be relaxed into the chair. Soft belly. Soft belly. If your mind wanders, bring it back to soft belly. Soft belly. Soft belly, soft belly, soft belly, soft belly, soft belly. Soft belly, soft belly, soft belly. You can slowly open your eyes, bring your attention back to the room. And I know that was really fast, but what I want you to notice is a sense of what's happening in your body, and just take note of it. And the most important thing is that you actually have to say soft belly out loud. And I know some of you may have fallen asleep. So the reason for saying the soft belly out loud is it gives you something to focus on and takes your mind away. Some of you may have noticed your mind starts to wander and starts thinking about things, and that's a normal process. After about 10 years of doing this, that won't happen anymore. So just forgive yourselves for doing that and bring your attention back to soft belly. And you can really calm down. So mind-body medicine techniques are very important to incorporate into your daily life. I suggest soft bellies for my patients at least 10 minutes a day, twice a day, if possible. Especially right before you go into sleep. It will really help you get more calm and relaxed. To relax your central nervous system, and it will relax your sympathetic nervous system as well. Thank you.
So it's official. I'm not inviting Dr. Jhaveri or Darlene to our tailgating party. I'm probably not going to invite you guys either, because all we're going to be doing is soft belly, eating right, and sitting up straight. So I'd like to invite our last speaker, Dr. Nick Thakur. He's actually the head of the Parkinson Center at Sutter, Sacramento. He and I have known each other now for 8 years. And really, it's been a pleasure working with him. Even though we both are of different healthcare delivery systems, we collaborate quite often. And I do want to clarify what Larry had mentioned before about our journal club that we do quarterly every year through the Parkinson Association. It really is just a vehicle for wine for us. But But we do get together with our Sutter colleagues, our Mercy colleagues, and our UC Davis colleagues to talk about new research, interesting cases, complex cases, and try to create a uniformity when it comes to treating Parkinson's disease. Because whether you are in the Sutter system, whether you're in the Kaiser system, whether you have something completely different, you're still a Parkinson patient, and you still have the same needs as anybody who would be within or without healthcare delivery. So I'm going to give the mic over to Dr. Thakur for him to give his talk.
Let's see here. So basically, we've heard a lot of good things so far, and I'm a movement specialist, and I often get the question, what exactly is a movement specialist? Are you a neurologist, or did you just train to treat Parkinson's and tremors? And actually, the training involves going through a general neurology residency, and then we do a fellowship, 1 or 2 years, focusing on Parkinson's and other movement disorders like dystonia, which is abnormal postures of the hands, which a lot of Parkinson's patients suffer from, chorea or dance-like movements, also seen in Parkinson's like dyskinesias from the medications, tics with Tourette's disorders, and as well as tremors seen with both Parkinson's and essential tremors. So we differ from the general neurologist, as the general neurologist focuses on a wide variety of neurologic issues, stroke, epilepsy, Lou Gehrig's disease, where we're more focused on the management of Parkinson's as well as movement disorders. And the key with that is we're more apt on the medication management, the surgical management, and this entails, great therapy overall, but the problem is not everyone has access to a movement specialist. Number one, maybe your insurance plan may not have one in network and you have to go out of network. Or secondly, the nearest academic center or movement disorder clinic could be 300 miles away because you live in a rural area. And so the key is how we get everyone the same type of therapy. As Dr. Khandhar had mentioned, we all want to do a standardization in Parkinson's care. So if you're seeing your primary care doctor who, as we heard before, doesn't know as much about Parkinson's as they do as diabetes and hypertension versus your general neurologist and your movement specialist, how can we standardize this? So if you are having to only be seen by your PCP, what can do to optimize your care? Was there a, oh, there it is, okay. Yeah, I'm managing 2 things. I wasn't smart. I didn't print out my talk. So there was a poster presented at the MDS meeting, the Movement Society meeting, this last summer. And this was looking actually at the mortality rate of Parkinson's patients over a time period and looking at what of those patients were managed by their GP versus a neurologist, meaning a general neurologist. And this was conducted out of the NPF, or National Parkinson's Foundation, and the University of Pennsylvania. And they noted per year there was about 48,000 mortality due to Parkinson's complications, meaning falling or aspiration pneumonia or these sort of things. And 7,000, almost 7,000 of those patients were possibly due to the lack of access to a neurologist, meaning they're managed by the GP. And 4,600 of these patients' lives were actually saved by seeing a neurologist on a regular basis. And they actually noted that a frequent basis seeing a neurologist was once a year. And I often see my patients every 3-6 months or so. So once a year made a difference. Infrequent was maybe once in 4 years. And obviously, some people have never seen a neurologist just due to lack of access. And the study also showed that patients managed by neurologists had a higher quality of life, lower chance of being placed in a nursing home, and less hospitalizations, which led to lower costs of care with inpatient nursing home as well as hospice care over a 4-period time. So that being the case, we're looking how we can change the medical care of Parkinson's disease, because the goal is to design a system where expert care is available to everyone, no matter where you live, what your insurance is, and because that's important, because we want the best outcomes for our patients. And so there is a telemedicine initiative. We're finally getting caught up with the Silicon Valley folks. Telemedicine is the future. And so hopefully you can sit at your home, log into your computer, and then you'll be able to see us without traveling 300 miles. This is already being done in stroke centers around the country where you'll have rural hospitals. You present with an acute stroke, and you see a stroke specialist at one of these centers, and they can give you a potentially life-saving clot-busting drug. And so hopefully movement disorder clinics will go in this avenue in the near future. It's just, time will tell. And then there's also research coming out on how Parkinson's specialists achieve better outcomes overall. And this study is called the Parkinson's Outcome Project. And that'll kind of be the focus of the rest of my talk. It's basically the largest clinical study following 7,500 patients from 2009 in 20 different Center of Excellences by the National Parkinson's Foundation in 4 different countries. And so they want to look at the patient's experience, assessment, and how they do better in the long run. And so the goal of this study, like I said before, is to ensure every Parkinson's patient receives the best care available despite, seeing a general practitioner, a general neurologist, or a movement specialist. And so they're going to explore the differences of the practices in these centers and what results in the best health outcome. And so the specifics are looking at the physician assessments during the clinic visits, the actual patient's experience of what they felt went on, and then lastly, the referrals to our colleagues over here, the physical therapist, the speech therapist, the dietitian, the counseling, how that changes the outcome, because I think we underuse our colleagues in general, and so that needs to be addressed as well. And so the mission here is to identify and explain factors that result in longer, better, and more active lives for Parkinson's patients. So far, I'm one behind, of course. Here we go. So far, with the 7,500 patients we have a range of ages from anywhere from 25 to 95, which represents more than 10,000 clinic visits. And this is the largest collection of patients of young onset Parkinson's, meaning younger than the age of 50. I think there's over 400 young onset, and so they want to see how their disease differs. And then secondly, it's also looking at patients who've had Parkinson's over 20 years, how they have done so well, and there's about, I think, 350 patients examining their longevity. And the key findings, what we see, the number one impact on life here of greatest impact on health is actually mood disorders, not the motor complaints, not the tremors, not the gait difficulties. It's more depression and anxiety. And over 50% of Parkinson's patients suffer from this. And basically, it's 2 times more than the motor symptoms. And this leads to increased disability, which causes problems with work, difficulty with engaging in social activities, and also engaging in exercise, as we heard earlier, is one of the biggest factors in helping your health. So if you're depressed or apathetic with lack of motivation, you don't have the motivation to go do a 30-minute bike ride or a 30-minute walk at a fast pace. You just rather, as Suketu said, hit the remote control, which is not exercise, except on Sundays, right? Football is important. So what is looked at this is these centers that do refer more for counseling results in lower rates of depression. Often the case is patients don't want to go and talk to someone, and that goes with a lot of chronic disease. They tend to, just stick with their family. They want a medication to help them feel better, or they just don't approach any treatment. And we see that with the combination of using antidepressants, medications, counseling, and then exercise, we result in the best outcomes for mood. And this will lead to, improved longevity, improved memory, improved cognition. So really, that's a critical aspect here. And then second was impaired mobility. That's the second greatest impact of health. And that totally makes sense if you have difficulty with walking, problems with balance, inability to do activities of daily living like bathing, cleaning, dressing. These will, significantly affect you overall. And these issues often lead to falls, injury, and even death with severe head trauma. You develop bleeding in the brain or a hip fracture, and then complications. So Again, going back to the biggest point I think of today is a well-designed exercise plan not only improves your overall health, but it can stabilize walking, calm your tremors, improve your mood, and possibly, as we said before, slow the disease progression. And I see this in my practice. People who are most active, they do best over the long run. People who are less active, they tend to progress at a faster rate. And so this is something that we've noted, and what was found in the study, regular exercise greater than 2.5 hours a week, which 30 minutes, 5 days a week, can result with lower degrees of mobility impairment, caregiver burden, and impairment of activities of daily living. And so I think that's the magic number there, 30 minutes, 5 days a week, or 2.5 hours a week. So, and again, it's any type of exercise you like, because all studies are positive, and this includes endurance exercise with, cardiovascular, bicycling, walking on a treadmill, resistance training with weightlifting, stretching like yoga, tai chi, agility training like dance therapy, and even the Nintendo Wii study was positive. So anything that, helps you out. So one thing that's been interesting with this project, you would think these Center of Excellence would kind of do things the same, meaning their medication, their referral rate, and what we found was a high variety of what goes on in the different centers. And I think this is based on how they were trained, where they were trained, what comfort level they have with certain medications, because the drug regimens from each center quite varied from each practice for similar patients. So that was one finding. And then the referral rate for allied health professionals was also different, meaning to the physical therapist, the speech therapist, counseling, and that varied almost 50% for a similar patient. And so this study is going to measure the outcomes. Does that referral rate change the overall condition? And then lastly, there was an inconsistent outcomes of health, meaning some centers did better than others overall. And could this be that some centers got the more advanced patients where the greatest changes may not be seen as someone who develops Parkinson's, early on, where you can, see changes overall? Or could it be that there's just superior outcomes at some centers, and they're going to look at that, what are they doing differently, and try to standardize this? So, to end this, the future of therapy, Parkinson's patients suffer or have very different symptoms overall in their disease, the rate of progression, and a reaction to their treatments, both medications as well as therapy. And then at the same time, doctors approach Parkinson's in very different strategies overall, which is unlike other diseases. In Alzheimer's, you have maybe 3 or 4 medications, you have cognitive therapy, and then in Parkinson's, there are really no established standards with treating Parkinson's, what to do at this stage. There is recommendations by the American Academy of Neurology, but, is a general practitioner following this, is a general neurologist, or even the movement disorder? They may be doing things as they're familiar with. With this outcome project, we anticipate standardizations of care because we have the largest diverse group of patients of receiving care around the world at the Center of Excellence, and this will develop for the best health outcomes and best treatments for our Parkinson's patients, no matter where they live, who is treating their Parkinson's disease, what insurance plan. This will be a standard of care, and hopefully this will be, in the near future. Thank you very much.
Thank you, Dr. Thakur. I want to emphasize that a Wii system is not a covered benefit. Ironically, I get that question asked a lot just around Thanksgiving time, just before Christmas. So we have a few minutes before we take a break. I do want to ask a couple of questions, kind of whet your appetite, and these questions will be directed to the physicians. The first question is it, and this is to Dr. Jhaveri really, is it necessary for a Parkinson patient to be seen by or to have a primary care physician that understands Parkinson's disease?
I think it's very important for all patients to see their primary care physician, but I'm not sure that they have to see someone that totally understands Parkinson's disease. The reason is that there are lots of things that your primary care physician should be doing for you other than treating your Parkinson's disease. They should be updating your immunizations. They should be making sure your blood pressure and your blood sugar are under well control. So I think that it's important for all patients to see their primary care physician, and I think it's not critical that they know and understand Parkinson's disease very well.
Okay. You have anything to add to that, Dr. Thakur?
Is this working here? Yes. Oh, okay. Yes, I totally agree with that. I just, want to add, I think an internist is most important versus a family practitioner. Not saying that the family practitioner has a lack of knowledge. I think the focus on adult problems as Parkinsons get older, they have complications from heart attacks, diabetes, that can make their Parkinson's worse. And seeing a, preventative care internist to manage or prevent these from recurring, I think is very important. So every Parkinson's patient needs a general practitioner, preferably an internist, yeah.
And then the next question is it necessary for all Parkinson patients to see a movement disorder specialist at some point during the course of their disease?
Okay, well, that's kind of what I touched on my talk here. I think that, it's almost at some stage of the disease, especially as the disease progresses, a movement disorder specialist can have therapies that could help overall, deep brain stimulation, managing the medication cocktails that we all have to lead to a higher quality of life, versus a general neurologist may not know enough about the, number one, surgical therapy, when to refer a patient, when it's needed, and sometimes the referral rates are, too late. As the disease advances, people develop dementia, we can't intervene. So I think at some point of the care, seeing a movement specialist, or, there are some general neurologists that are very apt. So it's quite specific on who you're saying, but in a general statement, yes, I think at some point in the disease.
To add to that, what some of the data suggests is that we have roughly about 2,500 to 3,000 Parkinson patients in the greater Sacramento and Roseville areas, which is a large population. That being said and done, between Mercy, Sutter, Kaiser, and UC Davis, there are about 7 movement disorder specialists, not all fully committed to Parkinson's disease. So if we do the math here, there is no way that every single Parkinson patient, even in our greater area, is going to be able to be seen routinely by a movement disorder specialist. But this is where you're talking about utility of telemedicine could actually play a role in where patients not only have their general neurologist, but they also would have the benefit of seeing a movement disorder neurologist.
Or maybe seeing a movement neurologist once a year that can give recommendations to their general neurologist and follow those guidelines. That would be another possibility.